benzodiazepines in non-substance abusers really don't get abused. There's an exception to any rule, but really people don't use benzodiazepines on their own.
Welcome to the 23rd episode of the MDedge Psychcast. I'm your host, Nick Andrews. In this edition, Dr. Lorenzo Norris welcomes Dr. Richard Balon to discuss benzodiazepines for anxious depression. Dr. Balon is a professor of psychiatry and anesthesiology at Wayne State University School of Medicine in Detroit. And don't forget to stick around for Dr. RK for a discussion on rage. And now, Dr. Lorenzo Norris and Dr. Richard Balon.
Dr. Balon, I want to thank you today for joining us on the MDedge Psychcast.
You're welcome. My pleasure.
Now, Dr. Balon, I found your recent article in regards to the use of benzodiazepines in the treatment of anxious depression very interesting. Now, I recall as when I was a resident in training, as well as for the most part, one could say clinical wisdom, if you will, that with an anxious depression, we normally treat either with monotherapy with an antidepressant, most commonly selective serotonin reuptake inhibitor, but you could also use a SNRI for that matter. And it certainly would be common to add a benzodiazepine such as clonazepam as an adjunctive treatment, but to then taper that medication off. I remember, again, in my training, for the most part, in terms of clinical wisdom, that one does not usually treat an anxious depression with a benzodiazepine solely as monotherapy. So I found your article very interesting in terms of questioning this, if you will, bit of clinical wisdom and how we approach patients with anxious depression. So I was wondering if you could elaborate a bit more on this.
Well, the issue is that we have never really talked about it loudly and clearly what should be done for anxious depression. Because originally when we had benzodiazepines and we used them for anxiety disorders mostly, then we started to examine them for anxious depression, and that was during the 1980s. There are a lot of articles by many psychiatrists, many of them were on using alprazolam in this indication, but also other benzodiazepines. And many of them were done in the United States by people such as Carl Rickles. And then the SSRIs came in, and they were touted as great for depression and then great for anxiety disorders. And we started to use them without any critical view. And we never compared SSRIs fully, especially in anxiety disorders, with benzodiazepines. If you look into the literature, there's very little comparing SSRIs, SNRIs, and benzodiazepines directly. While there has been the evidence, and the evidence has been buried in many articles, but nobody has put them together. But lately, the mostly Italian authors, under the first authorship of Dr. Benassi, but also Dr. Giovanni Fava, and I was part of that meta-analysis, we looked at the old data and put it together, and it showed that basically they work, benzodiazepines, as well as the old antidepressant, the tricyclics. And sometimes you can have clinical situations where you don't want to use an antidepressant. There are people who have serious side effects, don't want to use it, and in those indications especially, the benzodiazepines could be a good option. So I don't know whether that is a thing which answered your question, but we can expand on that.
Well, it does. What I've heard is that no one really looked back and did the work, and you and your group and fellow collaborators did, and you found that benzodiazepines, when you looked at it, were comparable to tricyclic antidepressants. Now, I guess then the question would be, there hasn't been work done, or to your knowledge, has there been work done in terms of comparing benzodiazepines to, say, selective serotonin reuptake inhibitors, say Pax paroxetine or fluoxetine as an example?
Well, there was one study which compared basically fluvoxamine and lorazepam, and there was no difference between those two in that study. It was relatively like every other study has been only 6 weeks, but it was double-blind, and everything, and really there was no difference between those two. But we don't have more stuff with the new drugs. We have only enough evidence from the older studies, which I think is not satisfactory. Even though I don't know who would do these studies, but it would be. Historically, we didn't also pay much attention to anxious depression. Because if you really think about it, you were right when you said we sometimes combine these two classes of medications. But if you really look at DSM and the symptomatology, I was surprised myself when somebody brought my attention to that. There's no anxiety among the symptoms of major depression in DSM-3, DSM-4. Only DSM-5 has an anxious distress specifier. So we didn't really think much in terms of that in a lot of official psychiatry, what is the role of anxiety in depression.
Now, again, going back to, I guess, kind of clinical wisdom, or what many people have been taught. You start an SSRI. It's very common to, if you will, again, start a benzodiazepine, whether if you feel so the patient actually does have anxiety, provided that they do not have. Most people would screen for a substance use disorder, but many people would start, again, whether a fluoxetine, a paroxetine, an escitalopram, along with a Klonopin, and the plan would be to taper it off, and at times people would actually start the benzodiazepine in anticipation of potential SSRI-induced anxiety. Now, and again, the study hasn't been done, but what do you think would be the benefit, let's say if we were to just hypothetically, of using benzodiazepine monotherapy versus just starting a patient on paroxetine and Klonopin? What might make you favor monotherapy over, for lack of a better word, the more traditional approach that's been taken over the past couple of years?
Well, you may not face the side effects of SSRIs. That would be one thing. You would probably get a very quick response. Which you can get if you combine these two medications too, but like you said, they also can make you a little bit anxious, especially, let's say, some SNRIs too and everything. So, and we also know from, I think it was from some articles, one of them was the evidence from STAR-D, that anxious depression doesn't really respond that well to antidepressant. We did not analyze the data enough, but if I remember correctly, if you remember the STAR-D study, which was examining how we treat depression, it really it was that the benzodiazepine, there was no benzodiazepines really involved in that, but there was more side effects among the anxious depressed people, and it took it took longer to occur in these patients. There was some improvement and everything. So I think these people may be less prone to respond well to antidepressants, and we need to examine that better, and they may be responding better to just benzodiazepine.
Okay. All right. The next question that I think is going to be on everybody's mind is, if you will, because obviously benzodiazepines are a controlled substance, habit-forming. Patients are going to certainly be at risk of, if you will, developing dependence. And many people are going to be concerned that, we're going to, by giving, if you will, a controlled substance where patients can develop, have withdrawal symptoms as well as develop dependence, that we could certainly, I won't say, be setting patients up for another problem down the road if we are using benzodiazepines long term without, if you will, a clear indication for it. And I wanted to know what your thoughts were in regards to those concerns about, if you will, patients becoming dependent on benzodiazepines if we were to use it as monotherapy.
I'm certainly not advocating using benzodiazepines in somebody who is addicted to, let's say, alcohol or some similar substances. On the other hand, there was an examination of this issue. There's a little book by the APA, and it's pretty old and people don't remember certain things, but it was done by a task force on benzodiazepine dependency, which established by the American Psychiatric Association and a lot of people together, and they concluded that benzodiazepines in non-substance abusers really don't get abused. And, there's exception to any rule, but really people don't use benzodiazepines on their own. If they abuse them, they abuse them usually with something else. The other thing is people usually talk about withdrawal symptoms. Well, like with many other medications, not only in psychiatry, there are some symptoms which appear when we stop the medication. Steroids, when you stop them, if you stop them suddenly, you will have withdrawal symptoms. So, and actually, a new problem has been appearing occasionally. I don't know what your clinical experience is, but when I have a patient on venlafaxine, for instance, I would not stop it suddenly. It's a very difficult clinical problem sometimes. They have withdrawal symptoms too, even though officially we call it discontinuation syndrome. So you have to do it judicially. You have to taper patients off the medication. And, of course, you're not going to give it to somebody who is abusing substances already. And then it could be basically fine. The other thing with which clinical issue which we are really forgetting is that what David Greenblatt, who is an old psychopharmacologist, said a long time ago, we don't cure with our medications. We treat it, which means that if you stop the medication, the symptomatology may come back. So if you stop benzodiazepine or an SSRI and the anxiety comes back, that does not necessarily mean that the patient is addicted or abused or whatever, abusing or whatever. So it's a clinical issue, and like with many other things, we have to approach it judicially and carefully and do what is the best for the patient.
Well, absolutely. I mean, as I'm hearing you speak, you're getting at the idea that even with certainly with many of our medications with shorter half-lives, paroxetine, duloxetine, as well as venlafaxine, to just give examples, that there can certainly be significant discontinuation syndrome if those medications are stopped abruptly. And I think it's many, in terms of clinical wisdom, and even out there, many people out there say, I personally have had the experience of having a difficult time tapering patients, not all patients, but certain patients, off of paroxetine, definitely duloxetine, as well as venlafaxine. So recognizing the difference between discontinuation symptoms versus withdrawal symptoms versus, if you will, recurrence or relapse of the original symptoms when the medication is taken off or discontinued or stopped abruptly is always going to be a challenge. I would probably say for myself personally, clinically, one of the biggest things that I would be concerned about is the risk of withdrawal with somebody abruptly stopping, if you will, a benzodiazepine. But going back to what you said earlier, if we were to trust the literature or what is out there, many patients who do not already have a pre-existing history of a substance use disorder should be able to take a benzodiazepine appropriately, as well as follow physician instructions. So now there's a lot to tease out. There's a lot to think about. Dr. Balon, because I'm still trying to, again, this is not clinical, what people normally do in clinical practice. So it's going to take a minute, I think, just even for me to wrap my head around it. But what do you think are the biggest impediments or resistance that a physician right now would have to actually using a benzodiazepine as monotherapy for anxious depression?
Stigma associated with benzodiazepines.
Okay.
Because, we can go to it right on the semantic level. You say it's withdrawal when you stop benzodiazepine, and it's discontinuation when you stop antidepressant. Why? Why do we call it with two different names? Because if you say withdrawal, that's the association of addiction and something terrible. So, and which is not necessarily true. But we call this antidepressant a different name. We use a discontinuation because we are afraid even to say withdrawal, because withdrawal is automatically associated with addiction. So many physicians are afraid of the substance abuse, but also they think that is clearly drug, whatever benzodiazepine we talk about. There are differences in between them. I would acknowledge that these drugs are really dangerous in using for addiction thing. As I said, like with everything else, clinical consideration is necessary. Certainly, I'm not going to prescribe it to somebody who's on opioids or who is drinking heavily, but I don't see a reason why not in other indications. And it's the same in anxiety disorders. We are using SSRIs for everything. Do they work that great for everything? They work for something they don't.
Okay, all right. An interesting point in regards to withdrawal and discontinuation. I probably leave that to some of my colleagues who are more experts in the area of psychopharmacology in terms of teasing that out. But this idea of stigma associated with benzodiazepines, now that is something I think not only, regardless of whether or not you're going to use a benzodiazepine for monotherapy or not, I think that there in general can be, I won't necessarily go as far as stigma per se, but I just definitely feel as though many clinicians, we have a certain level of, trepidation might be the wrong word, but caution, and appropriately so, when using, if you will, a controlled substance. But perhaps if we're not thinking about different and novel ways in which to use the substance and actually what the evidence base says, we may not be doing our patients the best service, particularly if they have predominant symptoms of anxiety. And that's just something, as you're talking about, that I'm really starting to think about. What would be, Dr. Balon, if you could yourself, given what we know, what the research is out there, what do you think, what would be a research study that you would like to see to answer any additional questions we would have about the use of benzodiazepines as monotherapy for patients with an anxious depression?
Well, I would like to see at least 3 arms. One of them being, let's say, a newer antidepressant, one of them being benzodiazepine, let's say Klonopin, and one of them being placebo, and do a long-term study, not just 4 to 6 weeks, but a little bit longer, and see what the outcome is. And I would like to, have some experienced clinicians like Carl Rickles is, but I don't know whether he's going to live that long to have a study like that. And that would be an interesting study for me. I understand the concerns about the substance abuse, and I'm as much concerned as anybody else. I wrote many things about substance abuse, but we are a nation who's legalizing marijuana right and left. And yet we are concerned about benzodiazepines. This is some kind of incoherent way of thinking for me. Well, I'm more concerned about medical marijuana than I am about benzodiazepines.
Now, you know what? That would actually be a very interesting sidecast. in regard to, because again, with the use of medical marijuana or cannabis versus the use of, say, something like Klonopin as monotherapy, which one are you more concerned about? That's I don't have an answer to that question, but I think that that's a very interesting question. It might be something that we could get a roundtable debate about. Because when you put it that would actually be quite interesting, because I myself have a number of, as I think most clinicians would, in terms of the use of medical marijuana for many conditions. And at least one could say, I am not in no way, shape, or form advocating at this point in time for the use of benzodiazepine as a monotherapy for anxious depression, because I do feel so you would definitely we'd want more studies, as you just articulated. But I would say one thing, though, in regards to benzodiazepines is that we at least know what we're working with. We have a bit more literature. We know the side effects. Many clinicians are very familiar with this medication. So I think that you raised an interesting question, and I do start to think about that. I never really considered to actually compare the use of Klonopin to medical marijuana in terms of things that we are that what is out there right now. So, Dr. Balon, sir, I want to thank you so very much for speaking with us on today's MDedge Psychcast. You certainly have given us a lot to think about in terms of reconsidering, or at least looking at, the use of benzodiazepines in anxious depression, and you brought up a number of points in terms of what the literature says and what it doesn't say, the role of stigma, if you will, that may be preventing clinicians from using a medication that is going to definitively treat symptoms. And for me, myself, you've given me food for thought. I can't tell you that I'm actually going to do it per se, but I will at least, you put it in my head to maybe ask the question in the appropriate patient who does not have a substance use disorder or any other contraindication, whether or not this could be something that could be indicated. Dr. Balon, thank you so very much.
You're very welcome, and I'm glad that you are going to think about it a little bit.
I am, absolutely, as well as the medical marijuana question. Very good. All right, thank you so much, sir.
You're welcome. Take care.
A big thank you to Dr. Balon for joining us this week. And now, Dr. Renee Kohansky.
Thanks, Nick. When talking about rage, people often think of road rage. Aggressive driving is pretty well studied. For example, the AAA Foundation found the following staggering statistics on respondents' self-reported driving behaviors. Purposely tailgating, 51% of respondents, or 104 million drivers. Yelling at another driver, 47%. Honking to show annoyance or anger, 45%. Making angry gestures, 33%. Trying to block another vehicle from changing lanes, 24%. Cutting off another vehicle on purpose, 12%. Getting out of the vehicle to confront another driver, 4%. Bumping or ramming another vehicle on purpose, 3%. And under the right circumstances, even the most actualized and evolved have probably tapped into their own experience of sudden rage for seemingly minor infractions. Specifically, I mean not acting on aggressive behaviors or impulses, just knowing about them. But we are in the business of psychiatry here, and we recognize that aggressive thoughts and impulses exist in everyone. So what kinds of things can trigger these thoughts? All right, we're talking about driving, so somebody cuts you off when you're driving. Waiting in an endless phone queue without ever speaking with a human. Press 3 if you don't understand what I just said. Someone takes a place out of line. Someone misrepresents something you said. Let's go a little bit deeper. Someone insults your child. Oh, and here's one in today's highly charged climate. Somebody dares to say something of a political nature that's opposite to your viewpoint. And what is it that's experienced? A quickening of heart rate, pupil dilation, the urge to defend, activation of fight or flight. Don't forget there's also freeze, but I'm not talking about that at this moment. And some situations are more likely to elicit the response than others. One could easily imagine that the right threat, and I'm talking minor, I'm not talking about the ones you actually need to defend, delivered at the right time, and it's possible a few choice expletives might pop out of your mouth. And what is it about these threats that go so primal? Well, for one thing, we're territorial creatures. cut someone off driving, or take a place out of line, and you're moving into marked territory. What else? Well, we're protective, and the primary directive is propagation of the species. Mess with our little ones, and you're tapping into a DNA-driven response. And yet, as I've said in other programs, we've got that squash of ours, that big old frontal lobe that puts the brakes on things. Someone cuts us off, we note the momentary insult, and then we can access higher cognitive functioning like, all right, it's no big deal, let them in. Or failing that, self-preservation kicks in, and we recognize the person doing the dangerous driving may be, well, dangerous. And we let it go because we value having all of our limbs. We live in tense times, often at the edge of our coping skills. Paying attention to our own experience of the world, particularly our less elegant ones, will help us understand, intervene, and treat when normal behaviors rise to pathological ones. I'm Dr. Renee Kohansky for the MDedge Psychcast.
That concludes this edition of the MDedge Psychcast. The Psychcast is published every Wednesday. You can subscribe to the show and find previous episodes wherever podcasts are found. For Dr. Norris, Dr. Balon, and Dr. Kohansky, I'm Nick Andrews, and this is the Psychcast.